Good afternoon and good evening, ladies and gentlemen, dear colleagues. It's my pleasure to welcome you to this webinar on urogenital tuberculosis. My name is Florian Wagenlehner. I chair the European section of infection in urology of the European Association of Urology, and I'm here with two very esteemed speakers, Professor Kulchavenya from Russia, Novosibirsk, and Professor Bonkat from Basel, who chairs the guidelines section on urological infections. So tuberculosis is a very old disease. It has been described first by Robert Koch. And as you see here on the right side, not only described the disease, he was also involved in measures and strategies to prevent tuberculosis. And as you see here, there are some preventive measures like not spitting on the ground, having a distance to the other, coughing not in the face of the other, which we are quite recognizing from the current COVID pandemic. So apparently the pivotal strategic and preventive measures have not changed too much. Now, Mycobacterium tuberculosis, and that is how Robert Koch did it, was first detected by a staining, acid-fast staining. You see here in red the acid-fast stained bacteria by the Thiel-Nielsen staining. And the primary organ which is affected, we all know, is of course the lung. And if the infection opens up and hits a cavernous situation, then the tuberculosis becomes open and becomes very infectious. Roughly 10 to 20 years after first infection of the lung, basically all other organs can be involved, and among those extra pulmonal organs, the urogenital tract is one of the most affected organs. For example, with tuberculosis of the kidney, with tuberculosis of the also male genital organs, such as epididymal tuberculosis, or for example, also prostatitis tuberculosis. And these affections of the urogenital organs often go unnoticed or are very difficult to diagnose. And therefore, we have this webinar today to shed some light on tuberculosis, because tuberculosis is among the most prominent infectious killers in the world. In 2020, an estimated 1.5 million people died from tuberculosis. And as you well know, it goes hand in hand with HIV infection. In 2020, there were also 150,000 people that were started on treatment for drug-resistant tuberculosis. So multi-resistant tuberculosis is a large problem, and only 1 in 3 patients who would have needed these drugs indeed received those drugs. So if we look what happened in the COVID-19 pandemic, then we see that the pandemic has severely impacted access to TB services worldwide. We know that 9.9 million people fell ill with TB, and only very little of those people received adequate treatment. So there's a large gap of diagnosis and treatment, also going hand in hand with the COVID-19 pandemic. So in my introductory summary, I would like to highlight that tuberculosis is very frequent and it's a deadly infectious disease. One of the big threats nowadays and in the future is multi-drug-resistant tuberculosis, which is already a public health crisis. We have to note that urogenital TB develops many, many years after the primary infection, when the primary infection has become forgotten, up to 20 years after the primary infection, and it often goes undiagnosed. Therefore, this webinar focuses on diagnosis and best management practices of urogenital tuberculosis. And here you see the speakers again. Ekaterina Kulchavenya from Novosibirsk, Russia, will now start the first presentation on recurrent cystitis and bladder tuberculosis, how to avoid mistakes in diagnosis, and that will be followed by a presentation from Gernot Bonkat from Basel on urogenital tuberculosis, a comprehensive review on a neglected manifestation in low endemic countries. So I think that at the end, we will have questions and answers after these two presentations. And just for housekeeping, at the end of this webinar is accredited with CMA credit points, and you will receive an email invitation tomorrow morning to fill in the questions to receive the CME credit points. Now, for the time being, I again want to welcome you to this webinar and hand over to Ekaterina Kulchavenya from Novosibirsk to give her first presentation.
I have no to declare concerning this lecture. Today we shall discuss these points. For ages, tuberculosis was considered as cold and congenital disease. Robert Koch first revealed Mycobacterium tuberculosis as a causative factor of the disease and presented his discovery at March 24 in 1882. And since then, all world celebrates this day as International TB Day. For his discovery, Robert Koch was awarded by a Nobel Prize. Interesting fact, I don't know how much Nobel Prize was, but Nobel, all money has spent on Bonkat. It is a photo of a real restaurant receipt, and before there is a remark made by Koch to his wife, "Sorry, darling, I promised to buy new shoes for you, but I spent all money." What is tuberculosis? TB is contagious disease. Only people or animals who are sick with TB are infectious. Latent TB means a person is infected but is not ill, and person with latent TB cannot spread infection. But person with active TB disease will infect on average between 10 to 15 people every year. Some words on epidemiology. Tuberculosis is a communicable disease that is a major cause of ill health. COVID-19 pandemic reversed recent progress in reducing the global burden of TB disease. TB is one of the top 10 causes of death worldwide and the leading cause of death from a single infectious agent. Yes, we lost many people from COVID-19, but mortality rate of COVID is 2% and mortality rate of TB is 15%. The most obvious impact on TB of disruption caused by the COVID-19 pandemic is a large global drop in the number of people newly diagnosed with TB and reported in 2020. At a glance, it's a good sign. We found less patients, but we see decreasing of the incidence because patients could not see a doctor. The most immediate consequences of this fact is an increase in the number of people who died from TB in 2020. Globally, in 2020, there were an estimated 1.3 million deaths among HIV-negative people, and in addition, 250,000 deaths among HIV-positive people. So incidences decrease and mortalities increase. What is extrapulmonary tuberculosis? TB in any site other than lung parenchyma can occur in the presence or absence of pulmonary TB. There is a rise of EPTB worldwide, and HIV co-infected people, besides being more likely to develop TB, get more EPTB, up to 50%. You may see on these pictures that TB infection may affect any organ, excluding nails and hair only. Even TB of placenta is possible. It was our patient, absolutely healthy young woman before pregnancy and delivery. From the end of past century till 2008, UGTB was the most common form of EPTB. Now, tuberculosis of bone and joint went on leading position. It's Professor Georges Marion, famous surgeon and urologist. He wrote, renal tuberculosis is extremely common. In the urology department, every fifth bed patient suffers from renal TB, and more than a third of all renal suppuration are of tuberculous origin. In 80% of cases of renal TB, the blood is also affected. The disease progresses slowly, death is almost inevitable. We have to understand that it was a period before creation of any anti-TB drugs. Now, diagnosis of UGTB is rare, but does it mean the disease is vanishing? From the end of past century, 1999, till pre-pandemic 2019, the share of UGTB decreased on 86%, and for 2020 on 30%. But is UGTB decreasing real? UGTB has no pathognomonic symptoms and hides under the mask of UTI. So patients with undiagnosed UGTB are treated with fluoroquinolone, zimicacine, amoxiclav, carbapenems, which have anti-TB activity. Then scenario may go by three ways. In some patients recover, since TB is generally prone to self-healing, and they received antibiotics with activity against Mycobacterium tuberculosis. In some patients with productive type of inflammation, the disease acquires a torpid course with frequent relapses and ends with kidney rippling and the development of chronic renal failure. These patients are considered as patients with persistent pyelonephritis resistant to standard therapy. In another patient with exudative type of inflammation, UGTB progresses and is complicated by urinary tract TB, hydronephrosis, pyelonephrosis, renal abscess, and rippling of the bladder. The disease becomes life-threatening if the patient is urgently operated in the general urological department, of course without neoadjuvant anti-TB chemotherapy. UGTB in these patients is confirmed by the pathological investigation of the operating material. We have found negative correlation between HIV infection and isolated forms of UGTB. I'd like to emphasize is isolated UGTB, because comorbidity pulmonary TB and UGTB, like any other forms of EPTB, have positive correlation with HIV infection. In comorbid patients, UGTB has features like in pre-antibacterial era with fistulas and cases. For decades, we have seen soul TB epididymitis without separation. And this March, I felt deja vu, as I have operated a patient, similar one, in past century. What may we say on clinical features of urogenital tuberculosis? This picture demonstrates great variability of the frequency of most common symptoms of UGTB. Clinical features of UGTB depends on the region, its epidemiological situation, is it developed or developing, are anti-TB drugs accessible, etc. So UGTB has no unique clinical pictures, and it is one of the reasons for delayed diagnosis. UTIs mask UGTB, and the patient with pyuria and bacteriuria receive more and more antibiotics instead of to be investigated on UGTB. Most common masks are cystitis and prostatitis. First most common symptoms of UGTB are pain and dysuria, and usually they are considered as cystitis and prostatitis. Why do we overlook UGTB? Why this diagnosis is a surprise for us? In 2001, European Association of Urology recommended fluoroquinolones as a first choice for the therapy of acute cystitis. Fluoroquinolones were new, strong antibiotic, and we all believed in its endless force. The time is running fast. For recent years, fluoroquinolones are included from recommendation. It's Professor Bonkat, chair of team who prepared guidelines on urological infection. His lecture will be next. Fosfomycin and nitrofurantoin are on the first line as alternative. Cephalosporins, and there are strong recommendations. Do not use aminopenicillins or fluoroquinolones to treat uncomplicated cystitis. For many reasons, one of them, you may overlook UGTB. We used fluoroquinolones too widely, and now uropathogens are resistant to fluoroquinolone with frequency up to 75% in some regions. It's results of Russian Army study, and we may see that isolates of E. coli are resistant to fluoroquinolones about in half of cases. We keep enough of experience to conclude. Fluoroquinolones are strong, but potentially dangerous drug. Please look at this man. He had a prostatitis and received annually some courses of fluoroquinolone during 4 years, which led to sarcopenia. There is a model of T-short with label, I am collateral damage from fluoroquinolones. So, in June 2019, European Medicines Agency decided fluoroquinolones should not be used for the prevention of recurrent urinary tract infections, for the prevention of infection after surgeries or interventions in the urogenital system, including transurethral surgery or transrectal prostate biopsy, and for the treatment of sepsis. You see blood TB in terminal stage with extremely low blood capacity. All patients with blood TB 4th stage had addressed to the doctor for a long time and all received many courses of non-optimal antibacterial therapy. And finally, they lost their blood. Urinary tract TB, TB of pelvis, ureterus, blood, and urethra is always secondary to kidney TB. Urinary tract TB appears as an edema first. Next stages are infiltration, ulceration, and fibrosis. bladder TB complicates kidney TB in 46–85% and may lead to the shrinking of the bladder. Classification of bladder TB includes 4 stages. Bladder tuberculosis is a form of urogenital tuberculosis that causes the greatest suffering and dramatically reduces the quality of life of the patient, since the frequency of urination can reach 80 per day. What about diagnostic of urogenital tuberculosis? To estimate the diagnostic value of different kinds of disorder, the comparison of spectrum of low urinary tract symptoms was conducted between bladder TB and recurrent cystitis. 70 female patients were enrolled in the study. 35 had bladder TB and 35 had recurrent cystitis. This table shows a comparison of clinical features between bladder TB and recurrent cystitis. We see there are significant differences in the spectrum of low urinary tract symptoms in recurrent cystitis and bladder TB, which allow to suspect bladder TB in patients with dysuria, but none symptom was specific for bladder TB. So, by clinical features, we may suspect bladder TB, but we cannot confirm this diagnosis. Nevertheless, analysis of these symptoms allowed to create an algorithm for suspicion of bladder TB in patients with recurrent cystitis. Let's learn another diagnostic approach: endoscopy, bacteriology, or histology, which is more useful for diagnosis of bladder tuberculosis. 190 patients suspicious on bladder TB were analyzed. In 18, bladder TB was confirmed, and in 172, non-specific recurrent cystitis was diagnosed. Cystoscopy is non-specific and looks mostly like interstitial cystitis. We compared cystoscopy in patients with recurrent cystitis and bladder tuberculosis. And again, there are no endoscopic findings to confirm bladder TB, but there are some reasons to suspect this disease. Histology. We compared results of biopsy, recurrent cystitis, biopsy, bladder TB, and surgery bladder TB. Histology revealed specific TB inflammation in 12% only. In other bladder TB patients, lymphoid and infiltration, as well as fibrosis was found. Fibrosis is main reason for absence of histological finding. Too fast, we see transformation of granuloma in fibrosis. How to confirm UROTB by microbiology? Identification of Mycobacterium tuberculosis in urine is a very difficult task because Mycobacteriuria is inconstant and scanty. In bladder TB patients, Mycobacteria was found by culture in 11%, by PCR in 17%, and none by microscopy. Due to the slow growth rate, conventional solid culture systems, including Lenstein-Jensen's land and Middlebrook agar plate, always require 8 weeks of incubation before a negative result is reported. Of course, it's too long time for diagnosis. And very important is shortest time between collection of urine and its sowing. Optimally, it not be more than 40 minutes. Now, standard culture and standard media has low efficiency for UROTB patients. And the main reason for false negative results is non-optimal empiric therapy for UTI. What modern technologies of rapid TB identification there are? First of all, molecular genetic methods in TB diagnostic. Different PCR techniques, flash, real-time, synthol, DNA strip technology, high in life science for identification both Mycobacterium tuberculosis and non-tuberculous mycobacteria. In 2010, World Health Organization approved Gene Expert for identification of mycobacteria in different samples, including urine. Bactec MDR-TB system is a fully automated culture system, and it has been recommended for faster mycobacterial isolation from clinical specimens. Bactec is widely considered as the gold standard for the diagnosis of TB. But mycobacterial growth in Bactec also can go undetected, especially most aggressive aging strain. So, TB remains dangerous, deadly infectious disease. UTB has no specific symptoms. There is no screening methods for early diagnosis UTB, the high index of suspicion only. Culture on solid conventional media is cheap method, but efficiency is low. Molecular genetic methods are more effective than routine cultures. Patients with recurrent cystitis who don't rely on standard therapy are high suspicious on UTB. Low efficiency of standard therapy is not indication for prescription another antibiotic or for increasing the dose, but a reason for investigation on tuberculosis. I wish a patient to have the same excellent urination like pissing woman in the Picasso of the painting. Thanks for your attention. If you have any question, you will send it by this email.
Thank you, Ekaterina. Thank you very much for this straightforward presentation. This is a pre-recorded presentation. Ekaterina Kulchavenya is in Novosibirsk, and it's now during the middle of the night, so therefore it was the only possibility to include her in this evening webinar. So I think you have seen that if we look into the COVID-19 pandemic, that it might be true that the protection we used increased to some extent also the contamination and infection with tuberculosis. But on the other hand, there is a big gap in adequate treatment. And I think it became also very clear that diagnosis, especially of extrapulmonal TB, is very, very difficult. And I think the first and one of the most pivotal items and parameters to diagnose TB is to think about TB, that there might be tuberculosis mimicking any other disease. So in order to continue, I would like to ask now Gernot Bonkat to give his presentation on urogenital tuberculosis, a comprehensive review on a neglect manifestation in low endemic countries. Gernot, it's a pleasure to hear your presentation.
So, good evening, everyone. It's my pleasure to be part of the webinar. I would like to thank all the guys behind the scene for the organization and my colleague Florian Wagenlehner and Ekaterina Kulchavenya for being with me at this interesting meeting. So I would now like to speak about urogenital tuberculosis. First of all, I would like to introduce myself. This is my home city since a lot of years now, Basel, Switzerland. And of course, first of all, I hope that you, your families, and your loved ones are well during the COVID-19 pandemic and that everything will be better in the near future. Here you can see the time is running. 3 people die every minute on tuberculosis. And these are the dates from 2019. 1.4 million people died from tuberculosis, including 208 people or 208,000 people with HIV. TB is still the leading killer of people with HIV and a major cause of death related to antimicrobial resistance. About 500,000 million people fell ill with drug-resistant TB, and the same number we have of patients with HIV positivity. The tuberculosis has a number of names, synonyms. It was called consumption, the white plague, scrofula, king's evil, because it could only be healed by the touch of the king, the captain of all these men of death. Then there was found the name tuberculosis, and the name tuberculosis was introduced by a German doctor, Johann Lucas Schönlein, a long time ago. A lot of people were suffering in the history of tuberculosis, pharaohs. Tuberculosis affected art. Here you can see the birth of Venus. The model Simonetta Vespucci died hundreds of years ago on tuberculosis. She was considered to be the most beautiful woman in Italy. The Wild Wild West, Doc Holliday, died on tuberculosis. Then we have René Laennec, who invented the stethoscope. Then tuberculosis touched art. You can see fading away a nice picture done out of 5 photos in one. Then we have La Dame aux Camélias, the famous story told by Alexandre Dumas the Younger, which was transferred into the opera, The Fallen Woman or La Traviata by Giuseppe Verdi. And as we've heard already, Robert Koch discovered then that the bacteria behind tuberculosis is Mycobacterium tuberculosis. And what we can see here is that still in the 19th century, people were exhumed because people thought that the dead were killed by vampires, but instead it was tuberculosis. And here you can see streptomycin, which of course it's very important because it was one of the first anti-tuberculosis drugs invented by Waxman when he received the Nobel Prize for his discovery. Extrapulmonary tuberculosis, it's important that we know that tuberculosis can affect any organ, but the most prevalent and contagious form of tuberculosis remains the pulmonary form. From the extrapulmonary tuberculosis, urogenital tuberculosis forms represent at least 25% of all extrapulmonary TB cases, so it's a high frequency. We have already heard about the diagnosis, and we know that the clinical presentation might be very difficult, at least for us not experts who are dealing with the disease in Europe. I've seen my last patient with urogenital TB 10 years ago, a decade. It was in South Africa when I worked there for a year. I've never seen a patient in the last years in Europe. I do not know what about your experience. But what we know is that urogenital tuberculosis is a mimic and which can imitate a wide variety of other diseases. We have heard that most predominantly we think about UTI in the case of urogenital tuberculosis. And in the literature, there are countless case reports from countries with a higher prevalence. And therefore, we know that a light diagnostic or delayed diagnostic can lead to severe complications for the patients. For example, if you take the kidney out because you think it's kidney cancer, but then it's tuberculosis, and you have not treated the patient before in a correct way. The diagnosis, we have heard, we have the smear microscopy, we have the urine culture, we have NATs, nucleic acid amplification tests. We can today now use whole genome sequencing as well. We have the histological examination, and we have imaging. For the smear microscopy, it's important that we think about the examination using the Nielsen staining or the Aramine staining. With respect to urine culture, we know that we have to take at least 3 morning midstream samples. And you have heard from in the talk from Ekaterina Kulchavenya already that the current culture systems are very long lasting. Of course, we have the rapid nucleic acid amplification tests, like for example, the gene X, but it's always the same. The drawback of the PCR diagnostic is that you can diagnose, you know that there is some genetic material, but you do not know whether the material is coming from living or dead organisms. Coming to the imaging, we have a few options. So we have the plain X-ray. We have a technique which, at least in Middle Europe, is not used so many times anymore. It's the EVU, the intravenous urography. Then we have the ultrasonography, the CT scan, CT urography, the PET-CT imaging, and the MRI. All in all, we have to say that with our modern imaging in Europe, we have a very high rate of detection of urogenital tuberculosis, up to 90%. You can see 2 CT scans. On the left CT scan, you can see in the upper pole of the right kidney 2 tuberculous lesions. On the scan on the right side, you can see that both kidneys are affected. We have very delayed influx of the contrast media in the right system. And in the left system, you can see many strictures on the course of the ureter. Regarding the medical treatment, we have the 6-month regimen, and we have an intensive phase of 2 months with the well-known isoniazid, rifampicin, pyrantimide, and ethambutol. And then we have the continuation phase of at least 4 months. It's important to know that in many patients, you need a longer treatment, especially in patients with an impaired immune system. And often it's necessary to treat as well patients with urogenital tuberculosis longer. The surgical treatment, there's to say that in more than 50% of patients affected by urogenital tuberculosis, surgery will be recommended. Most probably it will be an ablative or endoscopic or reconstructive approach because of the reaction from your body or the body of the bacteria. And this reaction is slowly destroying the genitourinary system. Because of the very slow onset of symptoms, we find very frequently already destroyed kidneys or symptoms. So that surgery is definitely necessary. There is a controversy still regarding the best surgical treatment, and the standardized surgical plan does not exist. The heterogeneity of the disease presentation and the different classification systems, there are different classification systems which are not generally accepted, may explain this issue. And then as well, the optimal time for surgery is controversial as well. Some authors suggest a delay of 2 to 6 weeks after the initiation of medical treatment, up to 9 months in some cases. I think it's very important, as we have in Europe not this experience that we have, or that we have the option or possibility, which is great, to contact our friends, for example, Ekaterina in Russia, which has a very big experience in the field. So anti-tuberculosis drugs prior surgery, this is highly recommended. The optimal time for surgery is 4 to 6 weeks then, in many leader opinions, after initiation of drug therapy. And this is because we would like to ensure a decrease in active inflammation and bacterial load and to consolidate the lesions. Reconstructive measures should only take place after about 6 months of therapy. And now I would like to come to a few advices and tips from my side about problems I have discovered with the treatment of urogenital tuberculosis. That's a question. We have a patient with urogenital tuberculosis. Is he allowed to use a bathroom? There we can say patients with urogenital tuberculosis are allowed to use shared toilets, but with care. This is meaning the sitting position to avoid droplets, but it's not forbidden. Next question. Sexual transmission. Is tuberculosis or urogenital tuberculosis a sexual transmitted disease? And here we can say yes. Prostate and penile tuberculosis are considered sexual transmitted diseases. Sexual transmission is rare, but possible. Detection of mycobacteria in semen, therefore, condom use is recommended for at least 4 weeks after induction, recommended for anti-tuberculosis therapy. So, important sexual transmission is possible. Then the question, we have an urinary or urogenital TB patient on your ward. Is it necessary to isolate the patient? Yeah, I can say it's not necessary to isolate the patient with pure urogenital tuberculosis. What about the respiratory protection? Nowadays, we are all firm to wearing masks, and I still remember, now it's 15 to 20 years ago when we had the patient surgery, a female patient from Africa, in Switzerland, and it was urinary or urogenital tuberculosis, and there was no one was quite clear or know whether what kind of mask should be wear in the OR. So here we can state that FFP2 or 3 masks are not necessary with pure urogenital TB, meaning for surgery as well on the ward. Then, is it contagious? Is urogenital TB contagious? Okay, then we have to say that about 50% of patients might be contagious. Of course, if they have a fistula, which is considered a contagious per se, it's meaning when urine, pus, etc. are coming out of the body via a fistula. The infection caused most commonly through aerosol formation, which is very rare with urogenital TB. This is why it's not mandatory to wear these special masks in the theater. And nevertheless, an infection can also occur through inoculation of the pathogen percutaneous route if an injury has occurred with a contaminated object. This is meaning, of course, you have to be careful if you are using the scalpel. Now, I would like to thank you. My final statement for urogenital tuberculosis in Europe is that we have to be aware about it. We have to know that with the coming of more and more people into Europe from East or from African side, the number of TB cases is rising. And if the number of TB cases is rising, then the number of urogenital TB cases rising as well. Last year, we have published a study where we have compared the knowledge of European urologists with African urologists or even African students. And it was a question of commonly neglected diseases in Europe, such as schistosomatiasis, other diseases, and including urogenital tuberculosis. What we have found is that the knowledge of the diagnosis and treatment in such countries is much higher than in Europe. Therefore, I would like to strengthen the fact that it's necessary to educate ourselves, our colleagues about this disease, and at least that we think about it, that it might be tuberculosis in some special cases. Now, I would like to finish my presentation, and I would like to thank you very much for your attention, and I give back to my colleague Florian Wagenlehner. Thank you very much.
Thank you very much for this very encompassing presentation and lecture with straightforward recommendations. So we have a number of questions in the Q&A. maybe I will start and compile some of these questions. There have been a lot of questions on the right algorithm to diagnose TB. And there's one question about quantiferon test, for example. Is that something you recommend, quantiferon test, because the old Mendelmann 2 test or the quick test is not recommended generally anymore? Is that something you do, or do you recommend quantiferon test in blood?
The test might be helpful, of course, but what you have always to consider, now we are speaking from European countries, we might have an additional information, but of course the gamma interferon test is not 100% safe, and I think in the setting of urogenital TB, other tests are more helpful, like we have seen, for example, the Chinesen test, test with the urine, or the test with some material we take out of lesions. This might be more helpful than the gamma interferon test. But of course, it's a nice test because you can see whether you have an infection or not.
So just to be very precise, in urogenital TB, would you, if possible, always recommend to have a biopsy or to have some histological investigation after you did the urine culture? But we know that even PCR and urine culture have a positivity rate of not more than 60% roughly, I think.
So from my point of view, it's necessary to have the right diagnosis, because what you have always to keep in mind, if you say that the patient has tuberculosis, you start an intensive treatment, at least for 6 months. And the drugs, which are very well known, are not such nice drugs. They have a lot of side effects that we have to consider. And therefore, I think it's very important that we definitely have the diagnosis. We need the diagnosis. And then we have to make it via culture of a specimen or the diagnostic of a specimen. We have to do it.
Yeah, that's a very important point. We have a couple of questions on that about treatment of empirical treatment of tuberculosis. So that means you don't have a firm diagnosis, you have a high suspicion what to do. Indeed, I have always problems with that. As you indicated, I mean, you have a long-term therapy that might even lead to liver insufficiency. So you have a lot of side effects. And in addition, depending on the region of the world, you have in some regions of the world a high rate of multidrug-resistant organisms, where you need to know which antituberculotic agent you would like to use. So what is your idea about empiric treatment if you don't have a firm diagnosis?
Florian, I'm very sorry now, because I just received a call from my clinic, because one of my patients is there with a renal colic, not with tuberculosis. Therefore, I would like to ask you, and please forgive me, to ask me your question again. Sorry. No,
sorry. Just empiric treatment. If you don't have a firm diagnosis, is that something you would keep in your mind? Is there a role for that if you have a high suspicion, but you could never prove it?
I know. This is a very, very, very interesting question. I know from some experts in the field dealing a lot of times with urogenital tuberculosis that they sometimes start antituberculosis treatment without the proof of an infection. They are just going through the symptoms and the history. But therefore, it's a little bit sad that we cannot ask the question, Ekaterina, but I would always recommend as a Middle European citizen to have a proper diagnosis prior starting a treatment. Otherwise, I think it could be a little bit problematic.
Yes, I would also argue in that direction. So if at all empirical treatment should be only indicated in very rare cases, if possible, as you said, culture and molecular diagnosis as well as histology, I think, is one of the cornerstones of a diagnosis of urogenital TB. Maybe we can wrap that up again. There are a couple of questions. I mean, we touched the quantiferon testing. So there's one question for the tuberculin test, interferon gamma release assay. I think this is the quantiferon assay. So as you said, this can that differentiate between latent infection, active TB disease, or a past infection? Could you address that maybe? Because that's the problem with all these screening tests. They become more or less positive if you have had TB, if it's a latent infection, and if it's active TB. Can they differentiate between these stages?
In my opinion, yes. I think that the gamma release test is the test that will prove that there's a current infection still in place, and that the tuberculin test, which is not commonly used anymore, as far as I know, it's not so sensitive, if you would like to have the question.
Yeah, I think that's not recommended, I think, in Europe anymore. Therefore, the quantiferon test is recommended instead, or a proper Mendelmann 2 test, if I'm correct. That is still that's something that is recommended. But in any case, I think it would not substitute the direct proof of tuberculosis in the urogenital tract. It's always an indirect proof. Then there have been some questions on, I think that is also something we need to address, side effects or infection after BCG treatment. I think you could address those questions. I mean, it's quite,
so, at least with BCG, we can have side effects. Of course, most of you have a patient under BCG therapy, and to know that the side effects can be very mild, like irritation or a little bit pain, which could be handled with painkillers, analgetics. Then we have as well sometimes cystitis, or we have at least a UTI, which might be the case not of because of the BCG, but because of the introduction of the BCG via a catheter. But then, of course, we can have a very severe complication of the BCG treatment, which need mostly hospitalization. This is a BCG sepsis. It could be because the BCG bacteria, they are attenuated, and in some cases they might cause an infection. Again, it's for me a very rare disease. I have seen only one patient in my life. What about you, Florian? Have you seen a patient with a BCG?
Yeah, I think there is also something which is called BCGitis.
Yes.
So this is probably more frequent. This is, I think, some kind of an allergy, which is not a true septic infection of the attenuated BCG strain. It's more allergic reaction to the strain itself, or to the surface of the strain. But I have not seen, I must say, I have seen side effects, but have not seen a true tuberculosis sepsis after BCG introduction. There's an interesting question, which is to some extent an immunological question. Is there any difference in response to BCG in TB exposed and TB naive patients? That's quite an interesting question, which I probably cannot answer in detail, because I think the background of this is that if we have BCG in the bladder, it increases the immunity of the bladder, which is usually, the bladder has usually a down-regulated immunity for self-sustainment. And this is different in those patients that have BCG. This is what we want. We want to have a pro-inflammatory result in the bladder. But I don't know if this is different in those that are TB exposed and TB naive. Do you know that?
I agree. Same.
The same.
Florian, so I have seen an interesting question here. Yes. Can you explain on the concept that 50% of urogenital TB will need surgery? I used to think that drug therapy usually suffers.
Yeah.
I think Or you have an idea, Florian, about this?
No real idea. In my experience, I think 50% is quite high. The problem is that has been addressed by Ekaterina. The problem is that the infection, even after it is cured, causes a fibrosis.
Yeah.
And that is, of course, in some parts of the urogenital tract detrimental. And but if you have adequate treatment, I don't think you need, and if you have diagnosed it to be early enough, I don't think that surgery is warranted.
Yeah.
Of course, in late stages, that's a different scenario.
I think the problem is the late stages, because especially in low-income countries, for example, you have not the possibility to go every time to a doctor if you have some pain in your back or in the flank pain, and so most probably a lot of cases are delayed in the diagnosis, and therefore surgery might be necessary because the organ is already damaged.
Yes.
Too much. Yeah. A practical question: if have ureter stricture in a patient with a suspected tuberculosis, can we leave the DJ stand long time, not affecting the bladder? I think the question, as far as I understood, you have kidney TB, you have a stricture, and then it's the question, can you put the stent inside, and is there a risk that you can bring the infection down to the bladder? This is a good question, like all questions, I must say. Just from logical point of view, I would say, of course, there might be a risk or chance to bring down the infection to the bladder. But on the other hand, I must say, most probably the patient should be under treatment with a drug if you have already diagnosed. So I think what should we do? Of course, the urine has to flow, so the tube has to be or has to put inside. Of course, you have most probably started treatment, medical treatment as well.
Yes, agree. So maybe one last question. I mean, we have a lot of questions, so this is indeed a very important topic. For Professor Bonkat, so this is for you. What is your opinion about treatment, renal TB 9 months, or would that go with a 6-month treatment?
Yeah,
and when would you finish treatment?
Yeah, this is a little bit dependent or what patients we have. For example, we have heard that we have a lot of patients co-infected with HIV or immunosuppressed patients. In this patient, it is often recommended to go for a longer treatment. Whether you have to go in general for a 9-month treatment is on debate, but as I said, in patients with immunosuppressive condition, etc., I think a longer treatment is definitely necessary. The question how we can decide during the treatment whether we have options to monitor. Of course, we have imaging options where you can see that the lesion is getting smaller, is something what we have, but the treatment duration is mainly based not on imaging but on empirical data that we know that the disease should be away after such a long period of treatment.
So I think with this answer, I thank you very much, Gernot. I thank everybody in the audience very much. We still have 201 participants. And again, I have to thank Ekaterina from Novosibirsk, who is a real expert on TB. And in addition, from the EIU, Crystal and Julie, setting up this without problems. And thank you very much for everybody participating here and for asking so many questions. Now you will receive tomorrow the link for your CME questions to receive and gather your CME points. And from that, I wish you a nice afternoon or a nice evening wherever you are. And just a last comment, this webinar will be available as an e-course from the next week on. Online e-courses from the ECU school. They're all accredited with 1 accreditation point. And for more information, you will receive, again, the link at uroweb.org, education, online education e-courses. So again, have a nice evening and thank you very much for participating.